Good morning, good afternoon, good evening. This looking hard for polyps is one of the cornerstones of for colorectal cancer prevention, and this is the topic of this session. Our first speaker will be Raf Bisschops from Leuven in Belgium, that will talk us about one of his multiple topics of expertise, artificial intelligence for polyp detection. Thanks, Raf.
Thank you very much, Rodrigo, for the kind introduction. So it's a real pleasure to be able to give this talk on this new exciting subject in the field of endoscopy. I wanted to start off and try to ask the audience what they think about this. Do you think you will be using artificial intelligence in your daily endoscopy tomorrow, within 1 to 2 years, within 5 to 10 years, or never? So interesting to see what the view of the audience is on that. Because it is something that is here and it requires some investment. So the willingness to invest in that may be a little bit different from the imminent reality that we are facing right now. So, okay, well, I think this some of them are going to use it tomorrow. Wow, 23%. That is quite amazing. Okay, so let's go on with the presentation. So see where we are now. So I think to add on to that, it's still in its infancy, but it looks very promising. And it will be interesting to see where we will be ending in a couple of years. Why do we need it? Well, there are some challenges for polyp detection in general. We know about the bowel prep, we know about endoscopic equipment, but there are operator-dependent factors like fatigue, loss of attention because we do successive repetitive procedures, or we can be distracted by phone calls, people coming in to ask all kinds of stuff, or trivial conversations with the nurses. So this accounts for the 26% miss rate that we can see in back-to-back studies and CT colonography studies. We need to realize that when we talk about artificial intelligence, that in essence, from the start, these machines are stupid. So we need to teach them and we need to train them. So we need to put in a lot of data, especially because nowadays for polyp detection, we use a so-called deep learning training, where we develop predictive algorithms that we actually don't know how it works. But in order to make all these connections within the computer, the system needs to have a big input of data to hopefully provide the output that we want from this study to find a polyp. So it's important that we know what these data are, because the performance will depend on the training data and the validation study. So just to emphasize why that is important is the concept of overfitting. So it's perfectly possible that if you have an algorithm that it performs perfect in the training set, but not well in the validation set. So for instance, if you want to develop a system that detects UC-related neoplasia and you only use methylene blue pictures with the neoplasia in there, well, if you present a picture like this to the system, it will say, no, there is no dysplasia because it wasn't trained properly. So this illustrates why we need to have an insight in these training data. I want to thank Cesare for this slide, where we do have this for most of the systems. And if we don't have it, we need to be a little bit suspicious. So if we have multi-center data, a lot of data, probably the system will be better. So that's already an indication. And then we need to show that it works. And the first thing to do is to see, is it as good as the human ground truth? So therefore, we don't need randomizations. You just can have the system run like a dry run on colonoscopy videos and see if the detection corresponds to the expert detection as such. And we have good data for that. Overall, we're above 93% accuracy for the systems that have been published so far. So it does the job. It can work as a guide to show you where the polyp is in the system. But then the question is it also of clinical benefit? And herefore, we do need randomized data. We have some good, interesting studies available. We have an RCT where the endoscopist is compared to the endoscopist with artificial intelligence. And there's a recent back-to-back study where patients were randomized to CADe first or just plain endoscopy first. So this is the hallmark paper by Repici et al. That will be cited until the end of the century, I think, when we talk about artificial intelligence. It's about the GAI Genius, where more than 300 patients patients in each group were randomized to CADe or standard. And what was shown was that there was a significant increase in ADR from 40 to 55%, and also the number of adenomas per colonoscopy were significantly different. And although no non-experts were involved or low detectors, the positive thing about this trial is there's no difference in clean withdrawal time between the two groups. And also importantly, no increase in unnecessary resections for so-called positives by the system that were first not detected. And interestingly, the increased detection accounts for all the sizes and also for the site, whether it's distal or proximal in the colon, and for all morphology, whether it's cell output unchelated. And a recently published or available study online in Gastro is from the Chinese group, where a back-to-back study was performed with CADe first or routine first. And you can see that on a patient level for the ADR for the first pass is in favor, is the trend at least in favor of CADe first, where it was almost 35% versus 26% when standard colonoscopy was used. But on a adenoma level, you can see that the miss rate was significantly lower in the CADe group first, with 14% versus 40%. So these all indicate that there is an increased detection of polyps, and a recent meta-analysis confirmed this, where there was 36.6% ADR versus 25.2% in favor of CADe. So there is clinical benefit, but we still need to clarify several things. So how does the endoscope react with the system for a positive? Does it reject true positives? Does the endoscopist detect the things that are missed by the system? What does the endoscopist do with false positives, and what does the endoscopist do with true negatives? And that will be the most difficult part. And this one is very important for the validity of the system, and if there is no loss of attention for all the boxes that can appear. And one way to do this, I think, is with a recent study design that we introduced that will be presented at UEG this week and will be available online and got later, with a real-time unblinding to assess the additional value of CADe. So there's a second observer in the room and the endoscopist is blinded. And when something is missed by the endoscopist, the second observer will interact. So here the definition is a bit different from standard diagnostic, where you have obvious false positives like air bubbles in stool, and other positives that need additional investigation and maybe a polyp. And then we have the false negatives that are missed by the system, and the true positives that are detected by both endoscopist and the system. And this allows to have a composite endpoint of the polyps detected by the system and the endoscopist, where you can assess accuracy of both, which you can see in our hands in our system was comparable and non-inferior to each other. The miss rate of CADe was 3.5%, for endoscopists was 1.8%. So it's very reassuring to see that high detectors don't miss too many lesions. More importantly, we found only 1.4 false positive per withdrawal time, and another study from GI Genius showed some similar results, where only 0.7% of the mean withdrawal time was spent to false positives. And I think this is within the range of clinical acceptability. So in conclusion, CADe works and is here to stay. The first trials show good performance of systems with increase in ADR. In the future, we need to focus on how does quality of endoscopists affect the performance of the AI, and vice versa. May AI affect the technical performance of endoscopists? Is there de-skilling, loss of attention, and so on? So post-marketing follow-up of the quality of endoscopy will be imperative, I think, after implementation. Thank you.
Thanks, Raf, for this great talk. I feel that you showed that there are probably more data than we were expecting, but of course we need more data. For instance, Samir is curious to know if we need randomized trial for AI in low detector, and I would also say what is a possible role for training. And another question that is similar is if AI is for you ready for prime time screening. Can we include in organized program? So 2 questions: low detector, trainee, and organized program.
Yeah, very pertinent question. So I think we need to know this. In fact, all the studies now also create some kind of competition between the system, and endoscopists want to compete and be better than the system that's in the room. So there is the bias. So we need to have like larger trials where the systems are longer in the unit, so that sense of competition disappears and it becomes normal. And then it's important to see if there is a relation with the ADR previous to the endoscopist, because in fact, if you have a low ADR, this may be due to the fact that you don't expose the polyp to the system, right? And then it will not be detected. So this is a question, I think, to add on to your second question, that needs to be answered first. And then before there is widespread implementation and say, now we can use this safely and you improve your quality automatically. So that's why I say we need to continue to monitor the ADR of the endoscopist. And second, for the trainees, I think it can be a helpful tool to draw the attention to the polyps, but in the end, they also need to be able to drive without autopilot. So if you buy a Tesla and you always drive autopilot, you might be in trouble once it breaks down. So I think they need to be trained also to detect on their own, but there may be a role, and maybe that will be interesting to see, to have a group of trainees do it with and without, and see if their ADR increases more quickly with the system like this. So all interesting things that we can find out in future studies to come.
A quick question, quick answer, Rafa, from Asma. Is ADR the best target for a CADe study, or it should be adenoma per colonoscopy, or the advanced adenoma per colonoscopy? Just from your heart.
Adenoma per colonoscopy. ADR
Okay.
is not the best one. Yeah.
Thanks so much, Rafa, for your great talk.